Good evening, all. I welcome everyone who have joined on this Sunday evening to our webinar series. So, this is a special webinar series which we have started 3 years ago. It's called Legends in ENT, and we have done with five eminent personalities previously. And this time also, we have a very well known, eminent Professor Dr. Mohan Kameswaran sir from Chennai. He's the managing director and chief surgeon of a well known institute, which is the MRF. And also, he's a honorary professor of Mahatma Gandhi Medical College, Pondicherry, and also a honorary professor of ENT in SRM Medical College. So, here we would like to welcome, sir. Welcome for accepting.
Thank you. Thank you.
So,
Thank you.
basically, I was very fortunate enough to hear your short talk in Hyderabad 6 months back. That time we really enjoyed your short talk with Venkatraman Reddy sir, and that time I wanted to know more. You didn't have much time that day to speak, so I felt maybe we should know more about you, and this was been happening since long time. So anyway, we wish you to speak on your own, sir. You won't be asking any questions, interrupting. So whatever you feel, your journey, your stories, and your journey along this last 40 years, we want you to share with us and inspire us.
Thank you. Thank you so much. Thank you. I'll share my presentation.
Yes, sir.
Are you getting the picture on the screen?
Yes, sir. We are getting.
Okay. Thank you. So first of all, special thanks to Sri Krishna, Sri Harsha, and for Kishore Kumar for this opportunity. And at the very beginning, I want to disabuse notion that I am a legend, nothing of the sort. So anyway, still very kind of you. I shall share with you my story of the last 45 years, or probably even more, but 45 years as an ENT surgeon. So a lot of things have happened, and I shall looking back, I shall take the steps. But I think the I was wondering how to start, and then I remembered particularly. Uh, a very interesting tidbit about Louis Carroll, the author of Alice in Wonderland, and he said the best way to start is to start at the beginning. So that's what I shall be doing. But briefly, if we look at the long history of mankind, uh, if you see the development of knowledge or evolution of knowledge, it has not been a smooth progress. It's not been that at all. On the other hand, it's rather in fits and starts. It's a sudden period of activity and then sudden period of lull. So there's a period of stagnation when nothing happens for decades, and then suddenly, then a lot of things happen, and there are a lot of epoch-breaking discoveries, and there's this change the understanding of our world. So this is how progress of science, progress of knowledge has been. And reflecting back, I think even in individual's lifetime, it's something like that. We tend to reflect this pattern where our life is not one smooth progression. We have periods of sudden development, periods of inactivity, and then there's overall progression of life. So this is how most of our lives are. So I think this is a very interesting thing. But our specialty has really grown. From the time of Hippocrates and Galen, through the Middle Ages, through the Renaissance. The Middle Ages was a huge period of stagnation where nothing happened. And then we had the Renaissance, and then in the 19th century, things started, really looking up. and the specialty became on its own, grew on its own. And of course, the last 2 decades has been a really, really fascinating period. And I recall the words of Sir Isaac Newton that if I have seen further, it is by standing on the shoulder of giants. So this is something which is very, very true. So I was born in 1955 on the 30th of January, which is the Martyrs' Day, the day that Mahatma Gandhi was assassinated, which is why I was called Mohan. And both my parents were very eminent doctors. My father, Professor Padma Shri Kameswaran, was the director of the Institute of Otolaryngology at Madras Medical College, at the time the only institute in the country. And he was a man who mentored and created many, many teachers over several generations. And my mother was professor of pharmacology, and later she was a first lady dean of Madras Medical College, and later the first director of medical education in Tamil Nadu. And she was the first founder vice chancellor of the Tamil Nadu Dr. M.G.R. Medical University. I have the distinction of sharing a B.C. Roy Award with both my parents. So the only family where the father, mother, and the son have a B.C. Roy Award, and also distinction of sharing the Padma Shri Award with my father. And I think we're the only father-son combination who have got a Padma Shri in medicine till date. So that's something which is been something to be proud of for me personally. But both my parents are very eminent, doctors, and therefore it's quite a challenge trying to stay in this family to live up to their images and to their expectations. My father's family was all doctors. In fact, I'm the fifth generation doctor. My grandfather, his father, all of them were doctors. And my grandfather was, of course, a very important role model for me, my father's father. He was a surgeon, a district surgeon. Those days, general surgeons in British days, they were just general surgeons. They would do everything. In fact, the very first tonsillectomy I saw was when my grandfather did the old guillotine technique. The first cataract I saw was my grandfather operating. I'd seen him doing thoracotomies, laparotomies, cesareans, hysterectomies, everything. So, he is an all-rounder. That's how it was those days. And my mother's family, interestingly, they were all not doctors at all. They were all, basically lawyers and people who are very involved in politics. My mother's family was a family of freedom fighters. Eight of the family members, her brothers, sisters, and uncles, were all incarcerated in the prison during the freedom struggle. And whenever I used to visit my mother's family, the only talk would be about Gandhiji and about how the freedom fight went on and stories from the freedom struggle and so on. So two different backgrounds. My father's family was all very loyal British citizens. My mother's family was all, Gandhians. But it was a very interesting mix, and it gave me a perspective about, the various factors about people. My schooling was in Madurai, which is down south in Tamil Nadu, because both my parents were professors in the Madurai Medical College. I was a very bright student, and in fact, I finished my SSLC, as it was called those days, 11th standard, as a state ranker. I was, I think, state rank number 8, I think. And then I went on to join pre-university, which is a year before medical school, at this famous St. Joseph's College in Trichy, where three of the Nobel laureates from India, all three had actually passed from there, and also Dr. Abdul Kalam was an old alumnus of the institution. So it was a very famous institution, and a year there really helped me to shape my thoughts and my lifestyle. Then I entered medicine at the famous Madras Medical College. It was a glorious institution. It still is. It's one of the, I think it's the second oldest medical college in the country after Calcutta Medical College, started a year earlier. But the fact is that Madras Medical College existed even before that in the form of medical school. So it was officially made into a medical college later, but much before that. So it was the first medical school in the country under the British. I entered in the year 1971, and it was a very, very eminent batch. Just to give you a perspective, we celebrated the 175th year of the Modern Medical College about 20 years ago. We are now going, about 15 years ago, we are actually now in the 190th year. And in that year, our batch was adjudged as the most successful batch in the whole 175 years. So it tells you about the batch. We had three Padma Shris from the batch. We had two vice chancellors. We had about 52 professors. About 70 of us were working as in various positions overseas. So it was an amazing batch, and to be a part of that batch was a real privilege. I was a very bright student in medical school. I won in almost all the subjects gold medals or university ranks. The only medal I was not allowed to sit was for ENT because my father was a director of the institute. He forbade me. He said, "You could not. I can't sit for it." But one special medal I remember with great joy, and that was a gold medal in surgery. It is known as the Chipperfield Gold Medal, named after Lord Chipperfield, who was then the Surgeon General in the British days. And it's a pure gold medal, because there's an endowment of about 35 acres of wet land made for that medal, and the proceeds of which will be used for making a true gold medal. But that is not the important thing. When I went on the dais and got the medal, on the first row, my grandfather was sitting along with my grandmother. When I came down, I gave the medal to him, and he fished into his pocket and took out his Chipperfield gold medal, which he had got 50 years ago. And he kept both together and showed my grandmother and said, see the two gold medals. So that was a very emotional moment for me because a year later, my grandfather actually passed away after a stroke. So it was one of the happiest moments in his life, and I was very happy that I had shared it with him. Then, after I finished my MBBS, I decided to become a neurosurgeon. So that was one of my greatest ambitions. And I entered into the Institute of Neurology at Madras Medical College, which was at that time the mecca for neurosurgery and neurology. It is the first institute exclusively for neurosurgery and neurology in the whole country, and one of the largest institutes in Asia. It was founded by Padma Bhushan Professor B. Ramurthy, who was a doyen of neurosurgery. He was considered as the father of neurosurgery then. And I had the good fortune of being attached to him as a senior house officer. So a year in neurosurgery is an amazing experience. I actually ate and slept in the institute, and I went to my house only on two occasions in the whole year. One was for Diwali, and one was for the Tamil festival, Pongal. So only two festivals or 2 days that I had actually been to my house. All the other days I ate and slept in the institute. I would see my parents when they came to the hospital, briefly, but I lived my life there. It was a very, very interesting period. It taught me a few things. First of all, the fear of dura completely disappeared because I used to assist him. He used to ask me to open the dura, expose the tumor. So, I had plenty of experience opening into the brain and opening the dura and repairing it also subsequently. But I also developed a lot of respect for the tissue, particularly for the brain tissue, because every millimeter in the brain matters. And so this is some philosophy which sticks into your head at a very early date. It really was very useful for me in later years. Also, you must remember those days. We did not have a CT scan. There's not unheard of. There was nothing like that. All that we had was a conventional tomography, which was of no use in the brain. We had the famous carotid angiogram. So almost everybody who came with anything, the only diagnostic tool we had was a carotid angiogram. So I became an expert in puncturing the carotid, injecting dye into the carotid, and then getting X-rays done. I don't know how much radiation I had personally, but we used to do that for almost every case of brain tumor or anything which came which suggested a brain tumor or space opening lesion. So carotid angiogram was the investigation that all of us did, and the senior surgeon, it was my job to do it for almost every case, which I thought was required. And diagnosis was entirely clinical. So we used to have these famous meetings in the morning with neurosurgeons and neurologists discussing cases. And it was quite amusing to see how heated it was, almost coming to blows. Neurologists on one side and neurosurgeons on the other side, each calling the other, almost calling them four-letter words, but very, very interesting, episodes. But we totally dependent on clinical sense or clinical science for diagnosis. And very often, you'd open up and you'd be quite flummoxed by a completely different presentation inside. So it taught me the value of clinical medicine, though. So even today, when I see a patient, I do a tuning fork test, I do a laryngeal examination with the mirror. So all these are very important for me. I feel the pulse of the patient. So these become a second nature for me, and it has defined me the way I am. But at the end of neurosurgery of 1 year, I was offered a seat in direct MS neurosurgery course. So it's just started then in Madras. It was a 5 year course where I would be, entering Institute of Neurology and be there for 5 years and come out as an MS neurosurgery at the end of 5 years. But at the end of 1 year, I had my fill. I was not prepared for the amount of morbidity and mortality that neurosurgery was at that time. Of course, it has changed quite a bit now, but those days, every patient who came, had this massive surgeries. Many of them died because we didn't have great drugs, great antibiotics. Infection was very common. Morbidity was very common. Somebody would come in a wheelchair and go back in a stretcher, and so on and so forth. So, it really left a very depressing taste in my, throat. And so I said, no, I know this is not for me. So I then, my next choice was the ENT, not because my father was an eminent ENT surgeon. In fact, that was a bit of actually, I would say, a wet blanket for me. But even so, I had a very good idea about what is happening in various surgical specialties. And I could see that there was a lot of new things happening in the horizon in otolaryngology. And I thought that this would be an opportunity to take and to seize and move forward. So I entered into the Institute of Otolaryngology, and my father was, was the Kameswaran, was the director of the institute. Professor Swaminathan was the second director, Professor K.K. Ramalingam, and Professor Ramdas were the honorary professors. Very interesting period. All four of them were very, were doyens, great surgeons. We had a variety of cases. We used to see admissions of around 400, 500 outpatients and something like 70, 80 admissions a day. And surgery lists were phenomenal. So it was an amazing period. I was a very good student, and I was definitely considered as one of the best students in the batch. And I went for my master's examination in 1980. It was interesting because naturally, because I was appearing, my father was not examiner. In fact, he had actually gone on an assignment to WHO, so he was not even in the country then. And the examiner who came was Professor Sinha of AIMS. I was a little, concerned because I knew the politics in ENT, and I knew that he did not like my father. The reason was that my father had, they were very good friends actually, but my father had contested and won the AOI president post against Professor Sinha, which he took very personally. He had asked my father to withdraw. My father refused. So there was a little bit of, heated discussion between them, and there was a little animosity. So I was a bit apprehensive, but I said, okay, let's face it, whatever happens. So I went for the exam, and to my utter surprise and shock, I was not only I passed my MS the first attempt, I was awarded the Dr. P.V. Chirian Gold Medal for the best outgoing student by Professor Sinha. It is a medal which is given only in exceptional cases. It's not given every year. And it was given after a gap of nearly 15 years. At the end of the exam, Professor Sinha called me, and then he said, it was a pleasure examining you. I have with great joy, I'm giving you this gold medal. I have recommended that it should be given to you. And then later, he called my mother and he said, Lalita, I was apprehensive for coming. When I came, I realized that your son was appearing. If he was not good and I had failed him, they would have all said that it was because of the grouse I had against Kameswaran. But to my utter delight, he's done so well and amazing. And as an after remark, typical of him, he made one remark. He said, Lalita, I think he's taken after you and not Kameswaran. So, but that is the point that he got his revenge back against my father, I think. But he told me something after my MS. I went and met him. And then he said, you should leave the country because there's nothing more for you to pick up in this country. Go to Britain and start, getting further training. You must remember those days we had no, camera for microscopes. There was a side tube, a monocular side tube with which you could peep and see what is happening. But, you can imagine 30, 40 people inside the theater trying to peep through that single monocular tube. We had mallet and gouge, for mastoids. Hanging motors were a rarity. Audiology was, to say the least, it was primitive. So it was really, really, it's very minimal thing. The, the Indian scenario was quite pathetic, actually. We used to do diagnostic tests with tuning forks, pure audiometer, which was archaic. When somebody came and we did a tuning fork, if they had a conductive hearing loss, we would be very happy. All the posters will jump on them, grab them, take them for posting those cases. Somebody came with profound loss or sensorineural hearing loss was actually, a person non grata. So none of us wanted to know anything about them. A mother would bring a child saying that my child is deaf, and then that'll, your heart will sink because there's nothing that you could do. And you would look at the mother and you pretend to do a lot of tests and then finally tell her, yes, your child is deaf, and then give a letter for fitting a hearing aid, which was largely useless, and then send them off to a deaf school. So it was a pathetic situation. I was so upset with the whole thing. But things were improving. We started getting, I was there in the institute, we saw the first impedance audiometer. So that was a great development. And electrophysiology had started primitively, so we started hearing about the duet waves and so on. So, there were some things happening in the horizon, and you could see changes happening in the field. As I said, mastectomy was with mallet and gouge, and very often the only thing was, you open the antrum and then flush some water into it, and then immediately the surgery doctor or the assistant would ask you to close. So that was all the surgery that we did. But with the development of microscopes and the electrical bursts, metal instruments, things started improving. We started appendectomies. My father used to do a lot. The other surgeons slowly started doing. In fact, Professor Swaminathan used to do, Professor KKR used to do, all of them. Professor Ramdas was really, really good at it. So we started seeing things like staphylectomies and all that happening. But osteoplasty was still not, practiced at that time. Rhinology, the less said, the better. It was a blind, heroic surgery. It was totally blind. People would, first of all, open into the antrum. Caldwell luck was the most common operation. And through the antrum, go into the ethmoid, mainly the posterior ethmoid, and then into the sphenoid. And, there were even people doing, opening the cella through that. With a headlight, mind you, and sometimes occasionally with a microscope. But it was, heroic surgery. But people got away with murder. I don't know how we were lucky, I guess, but we did all sorts of major surgeries, with hardly any vision. Only head and neck surgery was practiced in a form that you would recognize today. We had parotidectomy, we did laryngectomies, laryngopharyngectomies, even ONCS procedure was done in the institute. we had good head and neck work going on, but head and neck was by and large then outside the purview of ENT science. Institute of Otolaryngology at Madras Medical College was an exception. But in all the other centers, general surgeons would take over the neck surgery. So we had quite a ordeal, but it was something that at least we saw in our MS days. So after my MS, I took the advice of Professor Sinha. I immediately went to the UK. 1981, January, I was in London. And a week after I went to London, and within a week, I had finished my PLAB, which was a stupid exam then. And then I had also finished the Part 1 examination of the Royal College of Surgeons, FRCS. So immediately, this is I consider as quite an achievement because within a week of coming there, finished both these exams. So I had applied for various centers. One of them was the Royal National Throat Nose and Ear Hospital at Gray's Inn Road, which is considered as learning in Britain, the Mecca for ENT. It was, in fact, the very first single specialty hospital in the world. It predated even Moorfields Eye Hospital. And I was told that it is impossible to get there because only local boys and the two blue-eyed, blonde-haired boys would ever get it. And to my utter surprise, I got selected and I was offered a post of senior house officer initially for 6 months and then a registrar's post. I was registrar to three very, very good consultants. One was Tony Cheeseman, who was a very young consultant who had just come back to UK after having spent about 2 to 3 years in the US, and then a year with Hugo Fish in Switzerland. And he was an excellent skull-based surgeon. So that was my first exposure to skull-based surgery, to see lateral skull-based surgery. That was a remarkable experience. And then Mr. Charles Croft, who was at that time, the only person who was doing laser surgery in the whole of UK. And he was doing a lot of work on lasers and particularly, on snoring, surgery of snoring and so on. And that was, again, an interesting experience. And finally, Dr. Omar Shaheen, who was a brilliant head and neck surgeon, was an amazing thyroid surgeon and a parotid surgeon, and also an all-rounder, who would open into the mediastinum, who would, so my first exposure to mediastinal dissections and so on was with him. So this is a really learning experience there. And then from there, once I finished my 3 years, I went to Glasgow as a senior registrar. Those days, there were very few senior registrar posts, so I was quite lucky to get one in Glasgow Royal. And this is a place where, we had abundance of head and neck cancer. So I was cutting head and neck cancers. You can imagine in one day, I have done two laryngectomies, uh, two thyroids, and one parotid, and so on in one day's list. So that's the kind of head and neck cases which used to come flooding there. It is notorious. Scotland was notorious, in west of Scotland particularly, probably because of the high intake of alcohol and smoking. But we had a lot of that. And during that period, I also had the opportunity. I was sponsored by the hospital to go and attend courses with Michael Portman in Bordeaux, which is an amazing experience for otology. And then to House Institute, where I spent about a month almost. And again, that was a remarkable experience because I got to know Professor James Sheehy, who was the father of posterior tympanotomies, intra canal tympanoplasty. Amazing man, and he was a great guide and friend to me all through my life. I came back and again I had sponsored a year later to go and spend 1 month with Professor Jean Marquet at Antwerp in Belgium. This is an unforgettable experience. For the Marquet, whose picture is what you're seeing, is one of the most celebrated, otologists in Europe. He was given a baron's title, so he was known as Baron Jean Marquet. And Professor Marque was the father of homograph tympanoplasty. He had, exquisite surgeon, and it was absolute delight watching him operate. I learned a lot from him, and he was also a thinker, and he told me something which later on defined my life. He told me, Mohan, the middle ear has been explored, re-explored, and re-explored. Every nook and corner has been looked at, but the new frontier is the inner ear, and that's where most of the action is going to be. He said, in your generation, start looking at the inner ear. So, that is something which left a very big impression in my head. So after my period, about nearly 6 years in the UK, I got an offer. The University of Glasgow had signed a contract with the King Saud University in Saudi Arabia to start a new medical college, which will be the first of its kind in the Middle East. And they wanted to send faculty from Glasgow to go and start the center. And they asked me if I was willing to go, and I said yes, because it was tax-free money, and it was something I thought would be very helpful for me, and also the challenge of starting a new medical school. So I came back to Saudi Arabia. I came to Saudi Arabia and started the first academic ENT department in the Middle East, which was a great experience because I had Saudi students. And to my surprise, I found that students, undergraduates from all over the world. I had experience in India, I had experience in UK, and Saudis were all the same, the same kind of thought process, same, jokes, same talks, and so on, attitudes. There was no difference. And these boys, they took to me. I used to love them, and they were very, very fond of me. They used to eat and sleep in the department as even as undergraduates. So in fact, such a thing that my dean started asking me why the students are not leaving the hospital and staying in the hospital even after their posting hours. So that's how they were involved. I then started. I wanted to start the postgraduate course. So we started the FRCS course there, and later on we also started the Arab board. And I was the examiner for both. We conducted the FRCS examination for Edinburgh, overseas exam, and so my own students, undergraduates, then passed out and became my senior registrars and colleagues, and eventually my co-consultant. So it was a really happy period when I spent there. We published a lot of research papers. We did a lot of interesting surgeries. I think in 1 year, my record was 22 acoustic neuromas in 1 year. So it was an amazing period when we did a lot of work and a lot of research and publications also. 94, I came to India, and this was at the instigation of my guru, my neurosurgery professor, Professor B. Ramurthy. When I came here once, I met him, and he said, "What are you doing in the Middle East? I know you're making good money and you're doing good work, but he said your work is needed here. So much of work to be done here. Come back and serve your own people." So that immediately, struck a chord in my mind. And so I went and told my wife, I said, this is the last year we're coming back. She never questioned me. She just followed me. So we came back that year after I gave my resignation. And I set up my practice in Madras. It was then Madras, not yet Chennai. And we started, ENT practice. I found, to my surprise, that ENT practice here was at a very, very basic level. So I started doing osteoplasties, which is really the first time it was happening here. I set up the first sleep lab. I started doing skull-based surgeries, acoustics, which is all completely new here. I bought and introduced the first KTP laser in India. And also, we did the first cochlear implantation in this part of the world in 1996. Very few then, in Hyderabad, center with Apollo. Then at that time in uh, Army, Admiral B.K. Singh had just started the first cochlear implant. So a few of us, and it was really, really challenging, but it was interesting because we were sort of fighting and we were setting a new trend. My first cochlear implant I can never forget. It was actually two young boys. One of them had lost both hearing and become profoundly deaf after an attack of mumps. Other boy after an attack of measles. Both in about 16 to 17 years. They had no money. They were very poor. And I had no money to buy, although I was absolutely convinced, that I had to do it. So I told my wife, I said, this is my dream. So immediately she said, I'll pledge my jewels and give you the money. I said, no, we'll go ask for a loan. So I went and asked for a loan from the bank and was promptly refused because they said, if you want a car loan, we'll give you, but not for a device which we cannot recover anyway. So luckily for me, this is where Providence acts. The general manager, my wife simply said, no, I don't accept, no, put me on to senior person. So we met the general manager. He asked me what it was. I explained to him the whole thing. And he said, Doctor, I don't understand what this is about, but you say it's for the deaf. He said, I will sanction the money even though I may lose my job for it. And the reason I'm losing is two reasons. One, looking at your face, I don't think you are smart enough to cheat. And secondly, I said, I have a deaf son, and if there's something that you can do to restore hearing in this country, and I want to be part of it, maybe God is testing me, he said. So then I said, my God, this is how Providence works. And so he gave me the loan. With that, I did the first two implants. And I can never forget the first switch on. The first time I did it in a soundproof room, in audiology room, switched on the boy. He was a very interesting story himself. But he said, I can hear the air conditioner, which I thought was rubbish because none of us could hear it. I thought he was, having, over enthusiastic. Then he told me I can hear a phone, and I couldn't hear a phone. So Ranjit was then, junior audiologist. Then his uncle was a senior audiologist. So I'd asked Ranjit to go and check up. He went and he came back with his eyes wide, saying, "Sir, the phone is ringing in your consulting room, just two rooms away." So the boy could hear it, with his implant. We couldn't hear it. So that was a moment of epiphany. There's a moment of realization. I suddenly realized that this is my life, job. This is the this is why I was created. The French have a beautiful word called raison d'être, which means the reason for existence. And I realized that this was the reason for my existence. And from then on, my whole life changed. And first 3 to 4 years, we hardly had cases. We used to have 3, 4 cases or 5 cases in a year. But from 2000, the results started coming out, and we started getting more and more cases. Everyone was against us. ENT surgeons were dead against. They said, this is you're all charlatans. People even went and said, these are unethical practitioners and so on. Audiologists were absolutely livid. Teachers for the deaf were willing to murder me. Everybody was against. But the one group which supported me were the parents of the deaf. And they formed an action group and they went around, showing the results of their children to various deaf schools. And we started getting more and more children from 2000 onwards. So this is a period actually of autological revolution, in my opinion. From 1990s onwards till about 2000 was the most important decade because a lot of things happened. We had advances in auditory processes, diagnostic modalities, surgical equipment and techniques. We had genetics coming for hereditary hearing impairment. Radiology, we had super selective invasive radiology was coming in. Diffusion-weighted MRI for cholesteatoma recurrence, surgical navigation, stereotactic selective radiosurgery. All this is happening in this period. So we can imagine the amount of knowledge explosion which is relevant to autology in this particular period. And then this resulted obviously in the biomedical engineering. I would say miracle of auditory processes, particularly cochlear implant. I think the credit must be given to our specialty as one of the first surgical specialties to introduce auditory implants, neural implants. So we are the very first people to have introduced a neural implant in the form of a cochlear implant and the forerunner for a bionic man. So we didn't understand when we started doing cochlear implants. We did not understand actually, the way it worked or the way it interacted with the brain. All that we knew was it was creating some signals which were picked up by the auditory pathway, and people were, getting hearing. We did not understand the various phenomena, but we started learning about neural plasticity. So we had an age limit beyond which we could not do. We learned about neural scavenging, that if you don't use a brain, part of the brain, some other part of the brain will take over. We learned about auditory signal processing. And above all, we realized that the brain is hungry for information. So, whatever information you gave, however primitive, it would take and make some sense out of it. So the era of cochlear implantation was born, and all of us were privileged to be part of this long journey. When we started, the only indication was the profound hearing loss in a normal anatomy with no benefit from hearing aid. But expanded indication started. When I started, the minimum age I could do was 2 years. Then it became 1 year. Of course, now it's 9 months. And we started doing in syndromic cases. We started doing in abnormal cochlear anatomy, multiple handicaps. We started doing in single-sided deafness, even with good residual hearing in children with cochlear ossification and so on. So the indications went on increasing, and we started doing more and more till we reached the present of the era of bilateral simultaneous implantation. So we realized that 2 years are better than one, and there's so many other benefits which come along with two-sided hearing. We also are in the period of electroacoustic stimulation, where, when contrary to what we did when we started, we just had to put a piece of metal into the cochlea. But today we are respecting the fine ultrastructure of the cochlea, so that we want to preserve the hearing that the patient has got and introduce a cochlear implant, so that we would have both acoustic hearing and electrical hearing, and the two could be combined by the brain, and a lot of advantages like music appreciation and better signal to noise ratio and so on. So the era of electroacoustic stimulation is also coming. Uh, so CA was remarkable. Is really doing tremendous amount of work for or benefit for people with profound deafness, but there were a lot of challenges, especially in India. Cost was a very big problem. Distance and then multilingualism was another big problem. And then I had a very embarrassing moment. I was asked to give a keynote talk in the Teachers for the Deaf annual conference in Chennai. So I gave a talk about cochlear implants and how it's changing the lives of the deaf and so on. At the end of it, one of the participants, a teacher, it was a huge packed audience, more than 1,000 people from all over the country. One of the ladies got up and she put up her hand, and I said yes, and she said, "Doctor, you're a criminal." I was shocked. I was absolutely shocked. In fact, I started getting angry, as sweating. And I said, okay, calm yourself. And I said, "Madam, can I ask you why?" She said, because, the cost of cochlear implant at that time was 6 lakhs, a lot of money then. She said, that cost, you can give hearing aids for, almost 600 children. We can give this, we have this, we have that, we don't, and you want to bring in a 6 lakh technology. So I said, "Madam, you're right. The problem is the cost of putting up a satellite. You can give free water to 100 villages, but we still put up satellite because this is known as scientific chauvinism. I'm a scientist. I make science available, but it's a role of society to make sure that it is equitably distributed. And society is me and you. So if I'm a criminal, so are you." I said, so I got away with my, gift of the gab on that particular occasion. But it got me thinking. I said, she had a point. You have a technology where you're giving only for the rich. So what about the poor? Who's going to look after them? At that time, I had Providence again played a role. And I was a doctor to the Chief Minister of Tamil Nadu, Kalaignar Karunanidhi, who was a great, thinker, author, historian. And somehow he had a liking for me. And one day, very casually, he said, "Doctor, I was thinking you're the only person who has never asked me for a favor." So I said, "Sir, I have really nothing to ask from you. I'm quite a happy man, don't want anything." He said, "No, no, no, that can't be. You must have something which you like." I said, "Sir, there is something I like, but I don't know whether I should tell you because you may murder me." He said, "Why?" He said, "It's very expensive." He said, "What is it?" So I told him, I said, "Just give me 5 minutes." So I had my laptop, I showed it to him with two videos. One video of a child, sign language, saying, "I went to school, I did this, did that," all in sign language. A very pretty girl. And the other one is my young boy who was talking on the phone to his mother, telling him the same thing. And the sign language girl, there was subtext below that. So I said, sir, both of them were born deaf. This girl, could not get a cochlear implant. This boy got a cochlear implant and he's able to talk. This girl cannot, so she is signing. Well, subtexts are fine for you to understand, but in real life there are no subtexts. So this child will never fit into society. So he looked at me and he said, "Why are you not doing cochlear implant for everybody then?" I said, "Sir, money. I don't. I need money." He said, "How much do you need?" So I was so clueless. I said, "I need 200 implants a year." Yeah, I thought it was a big amount. So he laughed. He said, "No, no, no. You're underestimating. You probably need about 2,000." But he said, "I'll sanction 500 implants initially under the condition that you also train Madras Medical College." I said, "Sir, gladly. That is my alma mater. I'm happy to do that." So that's how it started, the cochlear implant program in Tamil Nadu. And I trained not only Madras Medical College, I trained every medical college in the state of Tamil Nadu because I felt that everybody needed to do it. The magnitude of the problem was so much. So every district in Tamil Nadu today has a medical college, and every one of them has got a cochlear implant program. So the Kalaignar Kapita Thittam was what it was called, a mass social insurance scheme for all the citizens of the state living below poverty line, and cochlear implant was part of it. So everybody got a free implant, all children below the age of 6. And then today it became changed into the Tamil Nadu Chief Minister's Comprehensive Health Scheme. And more than 5,000 children in Tamil Nadu have got the scheme, have got cochlear implants under the scheme, making it the largest, social insurance scheme for cochlear implants in the world. It's a matter of pride, and it's something which I felt had vindicated the embarrassment that I felt on that particular occasion when that lady called me a criminal. Then the next challenge was the distance. So we realized that, if I did a cochlear implant for somebody who came 500 kilometers away, what happens to them for habitation? How do I expect them to stay here, leaving everything, their livelihood? So then we started developing the model called hub and spoke model, where we said if they can't come to us, we have to go to them. So we started creating peripheral habilitation units, what we call the satellite centers, in across the various parts of the state. So that children could have surgery, but then go back to their own places and attend habilitation in a center, just 2 hours drive from wherever they are. And this immediately improved a dropout rate from around 30%. We had 30% dropout rate before that, but after we started this, it came down to less than 5%, which is even better than many European countries. Today, cochlear implant is showing tremendous advances. Electrophysiology, radiology. We have got PET scans now, functional MRI, near infrared, NIRS, O2 PET, cochlear endoscopy, uh, future technologies. We already in the totally implantable cochlear implant is already there. Work is going on with Joachim Muller in University of Hamburg. I think it will be with us in another 2 or 3 years. Uh, Better noise and music perception, better fitting, remote mapping, habilitation, all sorts of new things are happening. And a lot of advances in technology like miniaturization, better microphones, better battery technology, better surgical techniques. Now we're talking about minimally invasive techniques, atraumatic insertion techniques, and improved coding strategies and so on. So a lot of things are happening. We don't need the patient now to come to us for mapping. We can do a remote mapping. If the patient is at home, we can do the mapping from the center. So all these are challenges and developments which are happening. Another new area which is coming up, a lot of promise is what is known as cochlear optogenetics, where instead of the electrical signals, we're starting to use light evoked nerve impulses with lasers and fantastic, much better frequency coding with this technology. Robotic cochlear implants are also now in the game. A lot of robotic surgeries centers are also coming up, and robotic insertion devices are even more relevant to us because they can control the rate of insertion. We know that we have to have smooth, slow insertion if you want to preserve the hearing. So this is all these are now available. I think it's the present. I won't even call them the future. And totally cochlear implantable cochlear implants are definitely in the card. It's going to come in the immediate future, I think. And then I had an opportunity to go to Harvard and spend a month in Harvard. This was a real experience. It changed a lot of my thinking. I had the opportunity to work in the lab of a very, very young, bright, and brilliant otologist who is called as, Konstantin Stankovic. I was absolutely stunned. She had formed an alliance with one of the bioengineers called Ananta Chandrakasan. He was from Bangalore. He was from MIT professor. The two of them together, did amazing work. So they developed a prototype for a fully implantable cochlear implant, where a chip would be kept, in the middle ear beyond the tympanic membrane, and this would, transmit sound information. The chip would be charged through a smartphone while you're using a mobile phone for a phone call. Just 8 minutes to charge. It'll charge for a few minutes to charge, and it'll last for almost 8 hours. So this is a huge thing. I saw that happening. And then, even more important, her team said, "Why do we want batteries at all? Because that is the biggest challenge. Implanting a battery, and battery life would go in about 10 years' time." So they said the whole cochlea is a battery. It's got endolymphatic potential. It's a battery. Why don't we use that potential? But they actually had a work prototype working in a cat, but the amount of electricity produced from a single individual cochlea was not enough to power a cochlear implant. But I think they're working on it, and I think we may see that we may have devices which are running in the electricity produced by our own body. Genetics is, of course, the next frontier, to prevent rather than to cure. And genetics testing, in my opinion, will become an integral part of any work of a child with deafness. And many reasons for it, because we know that there are genes which will affect the cochlear neuronal population, like Myo6 and Myo7A and so on, where the population will go down. So your outcome of your cochlear implant, however well it's done, is going to be poor. Same time, we also have genes like the GJB2, where we know that the outcome is going to be, really, really good if you do a cochlear implant. So basically, you can even prognosticate. But the future is very, bright, and it is beckoning us, especially in genetics. We already know about gene therapy for hearing impairment, where we deliver genes via viral vectors and by adenovirus devices. And we all know about the child in CHOP, in Children's Hospital of Philadelphia, who got the autophyllin gene uh, for ANSD, congenital ANSD, and it was corrected after many years, and after 11 years, he started hearing without a device. So basically, this is a first of its kind, and then soon followed by Manohar Barnes in Cambridge, and Sue in Beijing. So there are three centers now which have done that. We are hoping that India will join the group, but basically, autophyllin gene therapy for deafness has already been established, and this is I think a path breaker with many more to happen. Stem cell therapy, there's a lot of work going on. The whole challenge is to not to produce hair cells, but to link these hair cells to the neurons. So this is where the real obstacle is, and a lot of adjunctive therapies have started coming in for hair cell replacement strategies and spiral ganglion cell replacement strategies. Uh, the realization came that with the cochlear implant, we are putting it into the cochlea and stimulating. Why not use the cochlear implant itself as a channel for delivering, drugs and materials which will act on the cochlea? So you could pass steroids, you could deliver growth factors, neurotrophic factors, again, adenovirus assisted delivery. All this could be done through the cochlear implant itself, which is a we can make a channel in it and then do it. So this is a new way of thinking now, as a cochlear implant, not only as a device to stimulate the neuronal population of the cochlea, but also to deliver material into the cochlea for assisting hair cell growth. And another very fascinating alternative way of thinking, also at the same lab in Harvard, as a sister lab, was the fact that they realized that you could actually make the hair cells develop into, I mean, the supporting cells develop into hair cells. We all know that birds are there. I mean, if you give gentamicin to a bird, it becomes deaf. And then a week later, it will once again start hearing because the hair cells have regrown. We mammals have lost that ability, and the ability is lost because of a protein called notch protein. So by suppressing notch protein, by an enzyme called gamma secretase, you can actually use this material way of, re populating the hair cells from supporting cells. So this is a strategy which they have developed in Harvard also, especially in guinea pigs. Notch inhibition causing cochlear hair cell regeneration. This is, I think, another big promise which is there in the future. Just to show you those images. And these are images of the hair cells population growing. As I said, the biggest challenge is not growing the hair cells, but connecting them to the neurons of the cochlea. Again, another way of thinking is to you have the cochlear implant on one side, and you have the neurons in the the modulus. To bridge the gap, by using a certain material, which will encourage the neurons to grow towards the cochlea. So here, BDNF expressing genes are injected into the cochlea of guinea pigs, and they help the neural fibers to grow and reach the cochlea. This will obviously, if you bridge the gap, it will sharpen the user towards pitch definition and much better dynamic range and so on from the same cochlear implant. The nanotechnology also has been now playing a very, very important role to act as a scaffolding between the cochlear implant and the neuron to encourage the neuritic growth. Another alternative approach is to introduce the piezoelectric membranes itself into the cochlea. So when the cochlea is agitated, the membrane will generate electricity, which will then stimulate the neuron. One of the most fascinating things for me is the development of what is known as the microendoscopy for cellular diagnosis. This is done with a two-photon microscopy. Generally, when we want to study the organ of Corti, we can only do it post-mortem and with electron microscopy. But now a technology is available where you can actually use a two-photon microscope and keeping it near the round window, you can actually study the hair cells. And these are images in a mouse. You can actually see the inner and outer hair cells and the tunnel of Corti. So in real life, in a living individual in vivo, you can actually start imaging the cochlea. This is a tremendous thing because we probably will now start looking at the pathology of the cochlea when the person is still alive. We are not waiting for him to die to get his cochlea. The next order of neuron is the brainstem. So what if you cannot put a cochlear implant? Either because the cochlea is not there or because the cochlear nerves are damaged during surgery. So, this is an auditory brainstem implant. And we did the first auditory brainstem implant in a 15-year-old girl with NF2 in 2005, which is the first of its kind in the whole of South Asia. And in a year later, we did the first pediatric auditory brainstem implant in a 2-year-old child. And this is the first in the whole of Asia and Southeast Asia, in fact, Asia Pacific region. And this is a tremendous thing. And I was called and I was asked to meet President Abdul Kalam, whom I started, developing a very close relationship, friendship with him. He was an absolute inspiration because he was a pure scientist. He was fascinated with cochlear implants and even more fascinated with auditory brainstem implants. He would ask me probing questions, and he started taking a great interest in the work that I was doing. And quite unexpectedly, in 2006, I was very surprised to see that my name was in the national awards list to get the Padma Shri award, even though I had never applied for it. It was entirely because of the kindness of President Abdul Kalam, who, from the president's office, decided that I should get it. So, this is a real surprise to me and a source of great encouragement for me and my team to carry on the work. So ABIs, is going on. And today we have the largest series of pediatric ABIs with more than 104 cases. It's been a real challenge and a journey. And it's a huge topic, we won't go into that. But suffice to say that, it doesn't give results like cochlear implants. You can't compare that. The best ABIs will give you results like, like an average CI. But that's about a third of the in the population. But it's unfair to compare the two technologies. They are different technologies completely. You can't compare an apple with an orange. But they definitely gave a sense of hearing to the children, and with a lot of work, a lot of sustained habilitation. Many of them develop speech, understandable speech, and may even get into normal schools. A lot of developments are happening in the field of ABI in the future, and we are partly excited to be part of the research going on with cortical auditory work potentials in ABI and PET scans, NIRS in ABI. So all these are being worked by our teams in Institute of Audiology, Murph Institute of Audiology, and also in Murph. And also during the period, I had the fascination of entering into middle ear implants. So the role of vibrant sound bridge, and today the bone bridge, and I had some experience with the Envoys team, the totally implantable middle ear implant. We did about 7 cases. Unfortunately, the company closed up, but it's a fascinating technology. And in all the 7 people I did, they had very good benefit for about 10 years when the battery ran out. A lot of future developments are happening in middle ear implants. I think the future is that of implantable devices. I think hearing aids will disappear very soon in the next decade or so. And most of the young ENT surgeons of today, where a substantial part of the otological work will be in putting in middle ear implants, to give people with moderate hearing loss hearing uh, much better fidelity than hearing aids. What next? Auditory midbrain implants, also cards for people who have such extensive NF2s with distortion of the brainstem. It's fascinating. You can actually put it to the inferior colliculus and give them hearing. And it helps their lip reading, enhances lip reading, and some environmental awareness. CP angle endoscopy, we had a brief, experience with it. I did about 70 cases or so, particularly for, people with hemifacial spasm and trigeminal neuralgia. It's a great thing for doing, as an adjunct to microscope for vestibular schwannoma and also for CP angle chorocidoma. We did a few cases of vestibular neuronectomy endoscopically for intractable vertigo. So all these are new areas which are happening. But I think the best indication is microvascular decompression with endoscope for hemifacial spasm. Vestibular implants are now coming in, and I think this is going to be, again, a very important development in the field of neurotology for people with Dandy syndrome or bilateral vestibulopathies. So this is something that is going to happen very often. Uh, in Japan, a lot of work is happening in tissue engineering, and I expect this is going to be the new method of closure of tympanic membrane perforations, where you don't really be needing to operate as an office procedure. You can start using the epithelial growth factors with a matrix to close perforation. So I think this is something which is very interesting. We need to keep a close watch on that. The last frontier in otology for me is eustachian tube. And I think the balloon eustachian tuboplasty is now coming in a big way. Our own center, a lot of work is happening. Dr. Raghunandan, my colleague, is very interested and he is doing a lot of work. I think the jury is still out there. In the next 2 to 5 years or so, we'll start getting meaningful results from various centers. But the initial results, coming from centers in the US, like from Professor Poe, Dr. Poe, and so on, is very, very promising. So I think, this is something that is going to again engage quite a lot of young ENT surgeons in the future. But overall, the specialty of otolaryngology is really, really transforming. We have a lot of endoscopes now, which are more and more miniaturized, enhanced optics, rotatable lenses, flexible tips. 3D endoscopy is now very much available. Angled endoscopes, all this has meant minimally invasive surgery, improved in vascular reconstructions, skull-based reconstruction techniques. All of them have implications in ionology, head neck surgery, skull-based surgery. Over the last few decades, a lot of development has happened in skull-based surgery. And I think the indications are still expanding. We are still, and the boundary between neurosurgery and ENT is becoming more and more fuzzy and hazy. Good example is the endoscopy of the third ventricle, pituitary, optic asthma. So all these areas which were originally only neurosurgical now being accessed by the endoscope by the ENT surgeons, of course, with with support of neurosurgeons. So a lot of work together, a lot is possible. One of the great developments, I think, is skull-based reconstruction. This used to be the biggest nightmare for us when we started work. And today, we have beautiful laser tissue welding coming in, where you can use biologic solder materials with albumin-based solutions, and they can actually help you to have watertight repairs of the skull base. So I think this is going to be something that's very, very important in the future for skull-based surgery. Surgical navigation, needless to say, this is really, really a game changer for us. We know exactly where we are, and it means we're going to get even better and better in our work. Robotic technologies, to help multiple surgeons operate at the same time, greater access for hard to reach areas, improved manual dexterity, and multi-port surgeries for multiple simultaneous corridors to provide optical access. So a lot of advantages in this. This is one apart from the Da Vinci system, new systems are coming in only for the head and neck, like the RoboSculpt, from the University of Eindhoven. A classical example of a TORS, transcatheter robotic surgery of supraglottic cancer. Virtual reality in surgical training is also now taking over. You can actually literally walk into the neck or walk into the brain, see the areas around, and then know where and understand the anatomy far better. Radiology has been supporting us with tremendous innovations in imaging, molecular imaging of tumors, and developments in interventional radiology, near field microscopy for special staining to identify tumor markers in head and neck cancer. And then, of course, exoscopic surgery is now also a buzzword. We have used it briefly. Somehow I found that in the depths, I still prefer a microscope. Maybe my brain is not adapting yet, but this is something which is going to develop also in the future. Uh, Not to forget the pharmacology. A lot of management of allergies are becoming, more rationalized. Immunotherapy is now coming in, more humanized monoclonal Ig antibodies. So these are all changing the way we manage, and one of the most common problems and vexing problems in ENT, which is allergic rhinitis. Lasers, a lot of lasers have come and gone. Now the new kid in the block is a blue laser, which seems to be a real gift in many ways. I think this is something which is going to be with us for quite some time. It virtually replaced CO2 laser in many centers in the US and many parts of Europe. OSA is again developing into a major subspecialty of our branch, and I think the future is hypoglossal nerve stimulation. This is going to be a real game changer once it reaches Indian shores. I think a lot of people are waiting for it to come. It's going to be a big development that we have. Uh, then you have advances in head and neck cancers now. We have IMRT, IMPT, proton beam therapy, new agents, monoclonal antibodies for PDT, photodynamic therapy. They're all changing the way we treat head and neck cancers. And molecular genetics is becoming a major field in head and neck. The next gen sequencing provides insights into the biological profile of a tumor. It allows us to consider new drugs which are specifically targeting the uncontrolled cell proliferation and the immune host response of the body to the tumor. Advances in investigations like the immunocytochemistry, PCR, RT-PCR, FISH, all these are changing the way we look at head and neck cancers. And head and neck cancers now, molecular biology is becoming important for molecular diagnostics. It helps us to have better staging, more better prediction of prognosis, and also to know the surgical margins and occult lymph node metastasis and so on. We have much better targeted therapies for head and neck carcinoma. Laryngeal tissue engineering is again a fascinating field in phonosurgery. And I think one of the big developments happening is the basic fibroblast growth factor, BFGF, for vocal fold regeneration, for vocal fold atrophy, and for presbyphonia. Medical nanotechnology, I already told you, is a huge area where when you go into micron size particles of materials, they change their character. So many substances which were like carbon, for example, which are considered as carcinogenic in a macro form, becomes a cancer therapeutic form in a nano form. So the whole biological behavior of nanoparticles is fascinating and a new area for young minds who are so inclined. So to conclude, several new and exciting technologies are the cards for the next generation, and I think it will greatly enhance the precision and efficacy of the surgeon. We have new tools in molecular biology, and they will add on to our armamentarium with much better diagnosis and therapy and more accuracy. Genetic engineering and stem cell therapy also will make a big impact in the management of several ENT disorders. I had a good fortune of living in through one of the most exciting epochs of ORL. From where I started with mallet and luge to where I am today, the surgery has completely turned upside down on its head and it's undergone a total metamorphosis. It's been a real privilege, to be part of this generation which saw all this transformation. I think it's been a really, really exciting ride all along. But I think I think the future beckons really, and I feel envious of the young ENT surgeons of today who are going to be seeing even bigger changes in the next 20 years to 30 years. I hope to live to see at least some of it, but I really my heart goes out in envy of the young ENT surgeons who are going to be seeing doing so much more meaningful work. So all the best to all of you. I think you'll all have a wonderful, wonderful, time as ENT surgeons. And you have done very well in choosing ENT as your career because I think it's one of the most fascinating and most rapidly expanding branches of surgery today. So all the best. God bless you all. Thank you for having me here today. I leave you with his thoughts, from Sir St. Clair Thompson. He who looks only forward seldom sees but one route. But he who looks backward may see several routes and can appreciate many of them lead nowhere, that some still point to promising lands have never been thoroughly explored. And there are not a few where paths converging on the broader road of progress, where we walk with so much confidence and with too much self righteousness. In other words, never forget the past when you're looking at the future. Thank you.
Thank you, sir. Wonderful summary and what a great journey. Really inspiring. So, I request the audience. It's not a question and answer session. Just anybody who wishes to speak can just ask any questions or anything. We are open.
Stop sharing.
Good evening, sir. It's really a wonderful session.
Thank you.
Coming
Thank
from
you.
Hyderabad during travel, in between, I'm seeing in the train. I watched everything. Really, you didn't left anything.
Thank you.
Everything covered from the basics to the advanced. Really having your lectures. Really wonderful, sir. Good evening.
Thank you. Thank you, Ryder. Thank you.
Sir, I also wish, maybe sometime in the future. So you give us a small talk on how do you run institutes? I mean, you have founded one of the best
I'm,
institutes.
I am the wrong man for that talk because I don't run the institute at all. I only come as a surgeon and operate. I'm very lucky. I
I
can
mean, I
answer you
wish
right now. I
we,
have some
yeah.
very, very good people around me who do all the work. So I just come and do my clinical work and my surgery. My wife looks after, she's quite smart
Mm.
in all that. Then I have Dr. Anand Kumar looking after the academics. Another very good friend is Dr. Jagannath, my chief anesthetist. He looks after the administration. So all of them are doing the work. I have a little role in actually running the
It need
institute.
a role model, sir, for to run a collaboration because we see all single man
Yeah.
institutes.
That is something that I think everybody should do. The future is that you should form teams.
Team.
Yeah,
We
teams and
rarely
then
see
work.
teams in ENT. Anyway.
ENT, yeah, because it's very difficult for one person to be managing, and it's also a terrible strain. It's unnecessary. So if you have a good group of like-minded people, each one having an interest in one area, then you refer to each other, you work together as a group, And the advantage is, like, like tonight, I'm going out of the country. I'll be back only after a week. I'm going comfortably because I know that I have wonderful colleagues who will cover me, in this period, 1 week. And they will see all my patients. They'll do whatever, any complications, I'll manage it. So I go comfortably, without any hassle. So this is something that becomes a big necessity, in today's world, in today's environment, where you have a group of people. And also, if you're operating, there is a difficult situation, you have people who can come and, give you ideas, help you. Not that they may be cleverer than you or not, but always two heads are better than one. And sometimes even the junior most person will give you a suggestion which is very, unique and useful. So I think having a group of people with you is the way to grow.
True, sir. Sir, one more thing. Which subspecialty in ENT are you are you predicting as a good?
Oh, I think we have the good fortune that there are going to be quite a few specialties which are going to be growing. For example, sleep medicine. I don't have to tell you already. In the last two American academies, I was shocked to see that two halls were dedicated only for sleep medicine for the whole 2 days. And the other major field coming up is pediatric otolaryngology, which is again a huge area. I think there's a lot of scope in India. There are very few people doing it, so it's a big area. Uh, as Jayakumar Menon keeps saying, laryngology is again a voice, is another major consideration for people to think about. Facial plastics, again, it's a huge, huge area. Already, I'm very glad there are some youngsters who have now started doing it in a big way across the country. Neurotology, is developing into a specialty with a lot of, future developments. I think with the coming of vestibular implants is going to change quite a bit. That's going to be another area to look at. So everything, I mean, head and neck is changing because of molecular genetics. Rhinology is changing to becoming more and more into skull base now. Otology is going to be a branch of auditory implants. So I think there's a lot happening in specialty, every single aspect. So there's so much of scope. So you can definitely tell your juniors to start looking at the areas which are less explored. For example, swallowing is one area which is not many people there. Big potential there. uh, in my mind, pediatric otolaryngology, there's so much of potential in this country. Airway, pediatric airway, and all that. So there is a lot of scope, in the field. I won't even say there's one subspecialty. There's so many possible, potential chances. But the important thing is, you have to be well versed in the basics of the specialty, no matter what you take. So, you should be able to do a tympanoplasty, you should be able to do a thyroid, you should be able to do maybe a parotid, no matter what you do, or you might do a good endoscopic sinus surgery for a sinonasal polyps. But you take one area and specialize in it and go into it in an area where you are really the king. For example, you may be taking up sleep medicine, and you are really, really good at it. A good example is my colleague, Dr. Vijay. He does a lot of very good work, basic work, but he's really, really involved in sleep medicine. Right now, he's in London University College lecturing there in the British Sleep Society. He's been ready to give 4 talks. So, it's a real honor. So he's really good at it, but that doesn't mean that he still does a very good thyroid. He still does a good tympanoplasty. I would definitely, if I had a perforation, I would ask him to operate on me, no problems. So I think that's the role model. That's the model that I would recommend. That you are a jack of all trades, but then become a master of one particular area where you are really world class. You are at the top of the notch in that level. So this will be the role model, I think, for the future young ENT surgeons.
Thank you, sir. Thank you. It was a great message, sir. So from the audience, we have Dr. Dwaraknath Reddy, sir. Sir, can you unmute? So just one question from the audience. What do you see? How do you see the role of artificial intelligence and machine
Yes, yes.
learning?
AI is going to play a role in medicine as a whole, in all areas, and is going to include in ENT too, in diagnostics, in the application of protocols, with various problems, and so on. It will take away a lot of our mundane work. I think that will be the advantage of AI in medicine. That a lot of work that we do is mundane work, repeatable work, which does not need the quality time of a consultant, and all that can be taken over by AI, and it gives you more time to start spending time on finer aspects of the specialty, more into research and so on. So AI is going to come. It's going to be a faithful assistant to us. It's not going to replace us. I think that's a very childish way of looking at it.
True, sir.
It's always going to be at our beck and call, but it's going to be a great assistant for us to help us to delegate a lot of our work, routine work, and then spend our time for things where we really want to spend time on.
Okay, sir. I think that's all for us, sir. I think you might be traveling, so we would not disturb you.
Thank you.
Thank you once again for
Uh,
giving us a small part of your weekend, and we hope to see you again, sir, in the future. Thank you once
Thank you.
again.
It's been a real pleasure. It's a privilege to be here with all of you. Thank you so much.
Thank you.